So we're here to just have a brief discussion about some indirect methodologies. Now, previously we have spoken about the concept of how to choose whether to use the direct barrier as a treatment method or the indirect barrier as a treatment method or a treatment approach. And what we're going to talk about within indirect is to describe why I would make the claim that when you're working indirect, the main goal is to make the soft tissue soft, or to make them squishy, or to take it to ease. So if you look at a system such as balanced ligamentous tension or ligamentous articular strain, so BLT or LAS, which, just in case anybody is confused, they are the exact same thing. There's just an early quote where the description, I believe it was by William Garner Sutherland, was ligamentous articular strain is treated with balanced ligamentous tension. So something along those lines was the quote. So some people just split them up. Some people, when they taught it, they would say one, other people would say the other. Therefore, we get this concept that they're separate, but they are the same. So the basic concept with BLT and LAS, as far as treatment is concerned, is a three-step process: disengage, exaggerate, and balance. So disengage essentially means begin to take it towards ease. Now, this system, or these systems, which are the same thing, tend to work quite well in situations that are quite acute, or at least the way that they're spoken of, it seems to be a little bit more appropriate when acute. But what you do to disengage, in the case of these systems, we'll take the ankle as an example. It's suggesting that what you would do is you would either create traction or compression, right? So you create traction or compression to create ease. That's the initial disengagement. So in those systems, disengagement means compression or traction of the joint surfaces, or of the joint that you're considering. But that compression or traction really is aimed at the soft tissues. So in this case, we'll just test, right? So we get, with distraction for this individual, what we get is some ease. Then the exaggerate is essentially take it more the way it likes to go. And you will have to do this likely in a multiplanar fashion. So what you'll see, you see me lean back a little bit, create the distraction, okay, create the traction. Now I'm going to start to, you'll see my body move, and I'll exaggerate just so you see. But we kind of go a little bit more towards ease, and I come into some plantar flexion. And that is the exaggeration for the balancing, for getting to that point of more and more ease. Now you can't let go of anything, so if I create traction as the initial disengagement, I have to maintain it. So then it's essentially hold, right? You hold, you wait. The concept is that there's going to be some form of release. The bone or the bony surfaces will go back to a more appropriate place, and then you're done. So initially you would have done some form of diagnostic, then you do your disengage, which is either compression or distraction, depending on which one provides more ease. The exaggeration is in a multiplanar fashion, go towards more ease, and the balancing is essentially holding, then you come back. So we've got BLT and LAS, disengage, exaggerate, and balance. If you're looking at another indirect system in the form of facilitated positional release, what you get is neutralize the anatomy, right? So get it to a neutral place, so essentially the tissues are softened. So it's finding that ease first. So with respect to the vertebral column, essentially flatten the curves is what is said. So in the lumbar and cervical regions, you would create minor flexion. You can do that by putting the patient on their stomach, or you can do that by pillowing, or whatever you need to do. You flatten the curves, essentially create facet idling, which will ideally create some soft tissue shortening or softening first. So initially you're trying to soften. So in the case of the patient here, I start to look for some softening. So if we're talking about facilitated positional release, I look for some softening first. Then I create my activating forces. So the activating forces, as we've spoken about in previous videos, we go through it algorithmically, right? So compression, distraction, torsion, right? And then shear, okay? So what we do is we try to identify what is going to do best, right? So for this patient, again, distraction, so we kind of go to ease, distraction, right? Compression doesn't help, distraction does. Then we create a torsion, it doesn't really do anything, right? Or rather, that was more of a shear, then we create a little bit of a torsion, that gives us a bit more softening. And then in the terms of facilitated positional release, from the gentleman who essentially created or described it in Stanley Shiowitz, he would hold for 3 to 5 seconds, he would let go, he would retest. One of the reasons he would do it so fast is because he had a lot of patients. So he was trying to get through a high patient load, which is why he did that. Now, from facilitated positional release, it is often in the way that Shiowitz would perform it. He would hold for 3 to 5 seconds, and then he would go direct. He would go the other way. Now, in going from that facilitated positional release, that indirect method, to a direct method, you essentially have the beginnings or an analog to still technique. So the concept of still technique is indirect, and when we say indirect, it's not necessarily clearly described when you're talking about still technique, but you go indirect, kind of go the way it likes to go, then you go direct, the way it doesn't like to go, and you would have, again, done an assessment prior. But what I want to speak about is that in all of these, the indirect, we are aiming to make soft tissues softer. So in these described systems, these described approaches, they consistently say whether they're adding an activating force in compression and distraction with BLT LAS first, or they're going to an indirect position to ease in FPR first, or in still technique first, they're all looking for that softness, that softening. Then, in the case of Stanley Shiowitz, in the way that he would do FPR, he would go direct after, or in the case of still technique, you go direct after, you're going to tension. So again, we just want to highlight that in all of these descriptive systems, including functional technique, which we're not necessarily going to show just because more often than not, functional technique works quite well in the vertebral column. It doesn't necessarily do a ton outside of the vertebral column, or it's harder to do. It's not impossible, but harder. But they all happen to go soften soft tissues first. If you're going to go direct after that, then you do so. Some of them talk about holding for different amounts of times. Either way, it's not a major issue because the commonality is make the soft tissue soft.